Okay, so in this lecture, we're going to cover the antihypertensive drugs. This goes along with chapter 21 in your book. The book is pretty comprehensive. There's a lot of different types of medications. I'm going to try to pare that down for you. I'm going to throw out some of the stuff which I don't think is that important and emphasize the things I do think is important and the things that you'll probably end up seeing in practice more commonly. So we'll start off with some background on hypertension. It's a very common disorder. It occurs in about 30% of the population greater than 20 years old. There are certain groups which it's even higher. African Americans, an example of that, where up to 45% of the population experience hypertension. And also the incidence increases with age. So the kind of standard definition for hypertension is a sustained systolic blood pressure of greater than 140, greater than or equal to, I should say, and or a greater than or equal to 90 on the diastolic blood pressure. And it should be confirmed. It's not a one-time reading. Um, the problem with one of the major problems with hypertension is that it's often asymptomatic. For those of you that have been to the screenings with us or are going to go to the screenings, you'll notice that patients that when we check blood pressures, a lot of them, sometimes they can be outrageously high, and the patient has absolutely no idea. They've never been to a doctor. They're not taking any medicine, yet their blood pressure might be 200 over 100. So it is often asymptomatic. That's why it's called a silent killer. Now, it can lead to some very serious complications: stroke, congestive heart failure, myocardial infarction, and eventually kidney damage leading to dialysis. So it's a major disease. It's a big problem. It's also one of the reasons that health screenings are important, because a lot of times you pick up people that had no idea that they were sick at all. So there's two major categories of hypertension. There's what's known as essential hypertension, so hypertension from unknown cause, and then there's secondary hypertension, which results from some type of other disorder. For by far, the most common that we see is essential hypertension. It occurs about 90% of the patients with hypertension. We do know that it's more common in certain populations. We know that there's probably a genetic component. And then there's some environmental factors, things that can be controlled, such as stress, high sodium diet, and then smoking. As far as the secondary hypertension, a couple examples of diseases which lead to hypertension. One is hyperthyroidism. The other is pheochromocytoma, which is a malignancy in the adrenal glands, which causes you to secrete a lot of catecholamines, so epinephrine, norepinephrine, which eventually lead to hypertension. So blood is normally controlled by several physiological systems. Um, Two of the major ones are the baroreceptor reflex and the renin-angiotensin-aldosterone system. For the baroreceptor reflex, we have, I guess baroreceptors that are located in large arteries. These are pressure-sensitive receptors which monitor and correct changes in blood pressure, and they do that by altering cardiac output and peripheral vascular resistance. So if you have a drop in blood pressure, it leads to compensatory actions. So you'll have an increase in the sympathetic outflow and then a decrease in the parasympathetic output that goes to the heart and the vasculature, which eventually leads in vasoconstriction and an increase in cardiac output. So those together will result in a compensatory rise in blood pressure. The other major system was the renin-angiotensin-aldosterone system. So when you stimulate that system, you can cause vasoconstriction due to the production of angiotensin II, which is a powerful vasoconstrictor. And then you eventually have a reabsorption of sodium and water through the effects of aldosterone. So angiotensin II stimulates the release of aldosterone, and its effect in the kidney is to cause sodium and water reabsorption. So those together increase blood volume and also increase blood pressure. Now, this diagram is another way of looking at that. Once you have a decrease in blood pressure, a few things that happen. One is you have an increase in the sympathetic activity, so your baroreceptors sense that response, and then they stimulate release of epinephrine, norepinephrine, and so they start doing their thing, and they stimulate all different types of adrenergic receptors, beta 1, alpha 1, and then that leads to increased cardiac output, increase in venous return, as well as increased peripheral vascular resistance. Another thing it does, it stimulates the release of renin, which we'll talk about down here. So the other thing that happens when you have a decrease in blood pressure is you have a drop in renal blood flow, a drop in glomerular filtration rate, and once you do that, you stimulate renin as well. So renin is then converted eventually to angiotensin 1, angiotensin 2. Angiotensin 2 is a powerful vasoconstrictor, so that increases peripheral resistance. It also stimulates the release of aldosterone, which increases sodium water retention, which increases blood volume. All this together further increases the blood pressure. Okay, so don't freak out about this slide. We're not going to do math, but there are a few equations that help you understand where some of the medications work. So the first equation is blood pressure equals cardiac output times systemic vascular resistance. We also need to know how you figure out cardiac output, and that's the stroke volume times heart rate. And the reason I'm going over these is because that's where a lot of the drugs work. Stroke volume can be affected by the volume of blood, so diuretics can affect that. Heart rate, a lot of the drugs, beta blockers, calcium channel blockers, clonidine, can affect the heart rate as well. Systemic vascular resistance, that's determined by the radius of the artery, so anything that causes vasodilation works here. So things like the ARBs, the calcium channel blockers, a lot of things work here as well. So most of these drugs lower blood pressure by affecting cardiac output or systemic vascular resistance. There are some that actually do both. In an effort to consume time, we're not going to spend a lot of time talking about the pathogenesis of hypertension. There is a nice discussion of it in your book, so please look at that. Be familiar with it. It is important. We just don't really have a lot of time to talk about it. I do want to mention real quick something called JNC8. Your book mentions blood pressure goals, and it references JNC7. That has since been updated to the JNC8. And the blood pressure goals are a little bit different in JNC8. So for the general population that's 60 years and older, so a little bit older patients, we'll allow their blood pressure to be a little bit higher. So 150/90 is when we would start antihypertensive therapy, with our target being less than 150/90. So everybody else, even people that have diabetes and chronic kidney disease, that used to be a different number because those people are at such a risk for complications like renal disease. But now for all of these patients, our goal we'd start medications at 140/90, with our goal being we want the blood pressure less than 140/90. Also, the change in JNC8 is now there are 4 major groups that we would use of medications as first-line therapy. That's thiazide diuretics, calcium channel blockers, ACE inhibitors, and ARBs. And we'll talk more specifically about those as we go through the talk. So the reason that this is important for you to know this, or the effects of antihypertensive medications, is they are going to have a significant effect on a couple things. One is the physical exam when you're evaluating a patient. Also, it's going to have a significant effect on the patient's ability or their response to some of the rehab interventions that you're going to be using. So you're going to really need to understand the pharmacology to fully evaluate patients. So this chart's from the book, and it's a nice summary of all the medications we're going to talk about. We'll start off talking about diuretics, and there's significantly different types of diuretics. And some are good for treating hypertension, some aren't. There's also the medications interfere with the sympathetic system. We'll talk about those. We'll talk a little bit about the direct vasodilators. We'll spend a pretty good amount of time on the medications that affect the renin-angiotensin system, as well as calcium channel blockers. Diuretics are some of the oldest, most effective antihypertensive agents that we have, particularly the thiazide diuretics. We'll talk about in the next few slides, but they are primarily what we use for treating hypertension. They all diuretics increase excretion of water by inhibiting sodium reabsorption somewhere in the kidneys. The common effect is a decrease in the plasma fluid volume. Thiazides also have other effects which lead to vasodilation, so they're particularly good at treating hypertension. The types of diuretics are the thiazide and thiazide-like diuretics, loop diuretics, and then finally potassium-sparing diuretics. So I won't spend too much time on this slide, even though I'd like to talk about it for about an hour and a half. This is, I don't know, I get excited about this slide, but it will bore you probably. So what you're looking at, this is a nephron, this is the afferent arteriole, this is the efferent arteriole, this is the glomerulus, this is Bowman's capsule, this is the proximal tubule, this is the distal convoluted tubule. I'm sorry, this is the loop of Henle, this is the distal convoluted tubule, and this is the collecting duct. So thiazide diuretics work in a specific area. They work actually in the distal convoluted tubule to inhibit sodium reabsorption there. Loop diuretics work, of course, in the thick ascending limb of the loop of Henle, where they block the sodium potassium 2 chloride channel, so they block sodium reabsorption at that point. And then finally, the potassium-sparing diuretics work more distally in the collecting duct, where they work most of them work in a place where sodium is exchanged for potassium. So if you block that, you block the sodium reabsorption, so more is lost in the urine. Fluid, of course, follows sodium, and then potassium is kept in the body. Therefore, it's potassium-sparing. So next we'll look at the thiazide and thiazide-like diuretics. These are considered first-line therapy for the treatment of hypertension, along with the other types that we mentioned in the earlier slide. They block sodium and chloride absorption in the distal convoluted tubule. Initially, it increases the sodium water excretion, which results in a decrease in the blood volume. Eventually, that normalizes, but you still have a sustained decrease in peripheral vascular resistance. Another thing it does it inhibits urinary calcium excretion, so calcium can actually increase when taking a thiazide. Now the thiazides listed over here, the ones most importantly what I want you to know is hydrochlorothiazide. That's probably the most common thiazide that's used. Next most common is probably chlorthalidone. Metolazone and indapamide are what we mean by thiazide-like diuretics. So they're not technically thiazides, but they work in the same spot and very much like a thiazide diuretic. So the adverse effects can be divided into two major groups. They can be classified as fluid and electrolyte effects or metabolic effects. The electrolyte abnormality that we see most commonly is hypokalemia, so a drop in the patient's potassium is seen in like 70% of patients that take thiazide diuretics. Very, very common. You can also have hypomagnesemia, so a drop in magnesium. Hyponatremia is pretty unique to thiazides. So low sodium occurs with thiazide, with patients taking thiazide, particularly thin elderly female patients, but it can be very significant. So just kind of know that you need to link hyponatremia with thiazide diuretics. Hypovolemia can occur with any type of diuretic, so very common there. As far as the metabolic effects, they're pretty interesting. Hyperglycemia is seen in about 10% of the patients that take a thiazide diuretic. Now, doesn't mean that we don't use thiazides in diabetics. We do it very commonly. Just know that it can have some effect on the patient's glucose. Hyperlipidemia is also a concern. You can have some an increase in cholesterol and LDL levels when taking a thiazide. Then also an increase in uric acid occurs very commonly, up in 70% of the patients. So you have to be very careful when we use the thiazides in patients who are at risk for gout attack. So loop diuretics, we'll discuss them. We'll talk more about those when we talk about the treatment of congestive heart failure. They're not really used to treat hypertension. They're more for the edematous states, so like congestive heart failure or people with liver disease and ascites. They work by inhibiting the co-transport of the sodium potassium 2 chloride channel in a thick ascending limb of the loop of Henle. So remember that at dinner parties, you can really open up some conversations with that line. So the effects with loop diuretics is you get a very strong diuresis. So it's very good at moving fluid. It just doesn't really, interesting enough, I guess, it doesn't affect blood pressure that much. Um, so the major agents for loop diuretics, most commonly, probably what you'll see is furosemide, which is also known as Lasix. Bumetanide is Bumex, and torsemide is Demodex. You will see those used. Ethacrynic acid you probably won't see used. The only time I've ever seen that used is in a unique situation where we needed to use a loop diuretic, but the patient was allergic to sulfa drugs, and furosemide, bumetanide, and torsemide all have a sulfa component. Ethacrynic acid doesn't, so in that situation we had to order it, so it's not like most people carry it. It's kind of unique, but that's your trivia for loop diuretics. The adverse effect of loop diuretics look very similar to what we saw with the thiazide diuretics, electrolyte abnormalities. Major effect is hypokalemia, so that also occurs with the loop diuretics. You can have hypomagnesemia, and you can also have a drop in your calcium. So that's unique compared to what you see with the thiazides. Thiazides actually can cause your calcium to go up. Also, of course, you can have hypovolemia. You can lose too much fluid if you're not careful with using loop diuretics. Metabolic effects are very similar as well. Hyperglycemia, hyperlipidemia, and then also hyperuricemia. So be careful with patients with a history of gout. So potassium-sparing diuretics prevent the secretion of potassium in the distal tubule and also the collecting duct. Um, they like loop diuretics are not really that effective for treating hypertension, so we're not going to spend too much time on them. They're often used to blunt, it says sodium loss. They're often used to blunt potassium loss. Um, Common agents are amiloride, triamterene, spironolactone, and eplerenone. Their mechanisms are a little bit different. Amiloride and triamterene block sodium-potassium exchange in the collecting duct, while spironolactone and eplerenone block aldosterone. So aldosterone works in the collecting duct, and it causes sodium loss with potassium. Sodium reabsorption and potassium loss. So if you block that, you get just the opposite. More sodium goes into the urine, and potassium remains in the body. Adverse effects are hyperkalemia, thus the name. And then also, and this is more trivia, also a good topic at dinner parties. Spironolactone is kind of a promiscuous drug. It doesn't only bind to the to aldosterone receptors. It has some affinity for androgen receptors, so it can lead to something called gynecomastia, also known as man boobs. So your book mentions a term which, quite honestly, I've never heard before. It's sympatholytic drugs, but it is a nice term to describe all the different agents which interfere with sympathetic activity. So some of these agents include beta blockers, which used to be some of the major drugs that we'd use for hypertension, which kind of fallen out of favor recently, as well as alpha blockers, which also aren't really effective for treatment of hypertension. I've kind of thrown out the presynaptic adrenergic inhibitors. They're so rare that I don't think you'll probably ever run across those. And then finally, the centrally acting agents, and we will talk a little bit about clonidine. So beta blockers historically have been considered first-line agents for the treatment of hypertension. However, with studies comparing them to other agents that we have now, they've kind of fallen out of favor. They're no longer considered first line. Now, there are certain populations which we would use a beta blocker in, but they're not our first agents that we reach to for the treatment of hypertension. As far as their mechanism, they reduce cardiac output by reducing heart rate. They do that on their actions on beta receptors. Primarily beta 1 would be their effect on the heart. Some of them are non-selective and they affect beta 2 receptors as well. Secondary effect they can have is on the renin-angiotensin-aldosterone system. So sympathetic activity stimulates renin synthesis, which then affects ultimately angiotensin 2 production and aldosterone secretion. So there is a secondary effect on the renin-angiotensin-aldosterone system as well. So beta blockers can be kind of divided up into different groups. There's the non-selective group. That's the beta blockers that block the beta 1 and beta 2 receptors. I've listed those here, and a good example of that is propranolol. So they're non-selective. So while they block beta 1, have the effect to slow the heart rate, they also affect beta 2 receptors, which can be a problem in people with asthma or something similar, reactive airway disease. Because remember that stimulation of beta 2 causes bronchodilation. So if you block the beta 2 receptor, then it could cause bronchoconstriction, or if the patient's taking something which stimulates that receptor, it can block that drug from working on the receptor as well. Then there's the cardioselective, and so these are medications that block only the beta 1 receptors. So examples, I've listed them below. Atenolol, metoprolol are probably the two most common used in that type. Some of the agents have something called intrinsic sympathomimetic activity. That's where they block the excessive adrenergic stimulation while they still have a normal stimulation of the from the sympathetic nervous system. So they block all the excess, but the drug itself causes some effect, which mimics epinephrine or norepinephrine. Pendolol and acebutolol are a couple of examples of that. And then some of the newer agents, in addition to blocking beta 1, beta 2, being non-selective, they also block alpha receptors, which can cause vasodilation. So carvedilol is an example of that. Labetalol is another example of that. You can get some pretty significant adverse effects with beta blockers. We mentioned bronchoconstriction with the non-selective agents. You have to be very careful if using them in asthmatic patients because of blocking the beta 2 receptor. Bradycardia is very common. You kind of expect that. Fatigue, sexual dysfunction, and then lipid abnormalities. You can see an increase in triglyceride and a lowering of HDL, which, as you know, is the good cholesterol. The next agents are the alpha blockers. We're not going to spend too much time on them. They are seldom used for the treatment of hypertension anymore. Now, where you will see them used is for the treatment of BPH. They do cause smooth muscle relaxation, so people with BPH is effective in that scenario. As far as hypertension, this mechanism of action, they block alpha-1 adrenergic receptors, which causes relaxation of the vascular smooth muscle, results in decreased peripheral vascular resistance, and also lowers arterial blood pressure. The common agents that you'll see used are terazosin, prazosin, and doxazosin. They do have some significant adverse effects. One is reflex tachycardia and first dose syncope. It's very common. The reflex tachycardia, basically you're causing significant vasodilation, and so your baroreceptors sense that and then stimulate epinephrine, norepinephrine, and then you have the effect on the heart is to increase the heart rate, so you have a reflex tachycardia. That can be prevented by giving a beta blocker along with the alpha blockers. I'll tell you that I haven't seen that used too much because we don't really use alpha blockers that much anymore for the treatment of hypertension. The other effect is postural or orthostatic hypotension. So when the patient stands up quickly, their blood pressure drops. So that is a significant concern when using alpha blockers. Clonidine is the most commonly used centrally acting agent, and it's primarily used for resistant hypertension. So it is never our first drug to use. You will see it, if people are on several medications, they will eventually add clonidine. Its mechanism is it's an alpha-2 agonist, and so when you stimulate the alpha-2 receptor, it decreases in the brainstem. It decreases sympathetic outflow. So the result is you have a decrease. So if you reduce the amount of epinephrine or epinephrine coming out, you're going to decrease the peripheral vascular resistance, and you're also going to decrease the heart rate. Clonidine is associated with some very significant side effects. People don't really like taking clonidine. It causes dry mouth, causes dizziness, and it also causes significant sedation. The next group of drugs are the vasodilators, or direct vasodilators. These cause dilation in the peripheral vasculature. They're usually used as last line in resistant cases or in emergency situations. So when you see somebody on these, you know that they've pretty much tried everything else and they can't bring it down. So most common agents are hydralazine and minoxidil. In emergency situations, you might see nitroprusside or phenoldiazepam used. They inhibit smooth muscle contraction by increasing the production of cyclic GMP. So therefore that leads to, so if you inhibit contraction, you lead to vasodilation is the thought. They have significant adverse effects. You can see reflex tachycardia, which you kind of expect with significant vasodilation. Also dizziness and orthostatic hypotension. Headache is very common. And then you can see hair growth with minoxidil, and you probably know that because minoxidil, topical minoxidil, is called Rogaine. So we actually use the adverse effect to our advantage. Well, I don't, but some people do. Agents that interfere with the renin-angiotensin system are very important for the treatment of hypertension as well as other diseases we'll talk about later in the semester. There's several different components. They all regulate sodium and water balance. They include renin, angiotensin 1, angiotensin 2, and finally aldosterone. The classes of agents are the ACE inhibitors, the ARBs, which are the angiotensin 2 receptor blockers, and then finally there's a direct renin inhibitor. ACE inhibitors are some of our most important medications for the treatment of hypertension as well as many other cardiovascular diseases, which we'll talk about later. They are considered first-line treatment. They're one of those four different types of agents which can be used first-line for treatment of hypertension. There are sometimes we use them first. An example is diabetic patient because of their effects in the kidneys. We will use an ACE inhibitor first to treat their hypertension because they have a protective effect in the kidneys, as well as people that already have chronic kidney disease. They work by blocking ACE that cleaves angiotensin 1 to form angiotensin 2. Angiotensin 2 is a powerful vasoconstrictor and also stimulates aldosterone secretion. So what you get is if you block the production of the vasoconstrictor, you get vasodilation. And also if you block aldosterone secretion, eventually you get reduced sodium and water retention. There are other effects of angiotensin which is important. Angiotensin 2 is a stimulator of vascular growth, leading to vascular wall hypertrophy. So there's I don't know what saccular growth is. I'll have to fix that. Vascular growth. There are other effects of ACE inhibitors outside of just their effect on blood pressure. ACE inhibitors have some interesting and significant adverse effects. One that you'll see is a dry cough. It occurs up in about 10%, and that's because ACE not only is responsible for the conversion of angiotensin 1 to angiotensin 2, it's also important in the breakdown of bradykinins, and so if you get a buildup of bradykinins, it can lead to a dry cough. There is also some thought that its effect on bradykinins may have something to do with its blood pressure effects as well. Also, because of their effect on aldosterone secretion, it can lead to hyperkalemia. Angioedema is also thought to be related to the bradykinin buildup. Is seen with ACE inhibitors, and it can be life-threatening. The other thing to remember is these are not used in pregnancy. They are fetotoxic, so you want to stay away from them in pregnant females, or pregnant males, I guess. The next group is angiotensin 2 receptor blockers. They are also considered first-line therapy for the treatment of hypertension. We also call them ARBs. So if you hear me say ARBs, I'm talking about the angiotensin 2 receptor blockers. They block the AT1 angiotensin 2 receptor. So they don't block the production of angiotensin 2, they block it from binding to its receptors. So you have very similar effects that you see with ACE inhibitors. The result is vasodilation and reducing sodium and water retention because you're also blocking the stimulation of aldosterone. The ARBs, adverse effects, you don't you don't see cough like you do. That's one of the good things about them with the ACE inhibitors. Now, that doesn't mean that you prefer them because they're usually more expensive than ACE inhibitors because ACE inhibitors have been around a long time. However, if you have a patient and ACE doesn't work, um, or they can't take it because of the cough, you can try an ARB. They still can cause hyperkalemia, and you don't use them in pregnancy. So aliskiren is also known as Tecturna, and it is our only agent that is a direct renin inhibitor. Now, this is a pretty new medication, relatively speaking. Um, it works by inhibiting renin's ability to convert angiotensinogen to angiotensin 1. So very similar to what ACEs do, just farther downstream. It results in action very similar to an ACE. So you have vasodilation because you're still not producing angiotensin 2, which is the potent vasoconstrictor. And also you will have less stimulation of aldosterone secretion, so less sodium and water retention. The adverse effects are kind of similar to what you see with ACE inhibitors. Hyperkalemia is a problem. Diarrhea is kind of unique to Tecturna. Cough and angioedema occur, but they're less common than what we see with an ACE inhibitor. The next group of agents are the calcium channel blockers. They are also considered first-line therapy for the treatment of hypertension. Primarily what are called the dihydropyridines fit in that group. Now, these drugs selectively block calcium entry either into the smooth muscle or also the myocardium. And it really depends on what class that we're talking about, where they work. Even though they're all considered calcium channel blockers, the different classes have significantly different effects. The dihydropyridines, I've listed those. The most common ones probably are nifedipine, amlodipine, and felodipine. They have significantly different effects than you see with the other group, the non-dihydropyridine agents, which include verapamil and diltiazem. The mechanism of action for the dihydropyridine is they block calcium entry into the vascular smooth muscle. So they are very potent vasodilators. So they have most of effect in the vascular, causing vasodilation, so lowering blood pressure that way. The non-dihydropyridine agents block calcium into myocardial cells. So it has more of effect on heart rate and myocardial contraction than it does in the peripheral vascular system. The adverse effects with calcium channel blockers kind of depend on the agent. Constipation is fairly common in patients taking verapamil. We see dizziness, headache, fatigue more common in the dihydropyridines due to their significant reduction in blood pressure, as well as peripheral edema with the dihydropyridine. So that's something we always have to tell patients to watch out for when they start taking something like amlodipine. Verapamil significantly reduces the force of cardiac muscle contraction. That's known as a negative inotropic effect. So because of that, we have to be very careful in patients with heart failure. It's been shown to increase mortality in those patients. So that is where we will stop. If you have any questions, please email, call, or stop me in the hallway. I'll try to, before the exam, I will upload some practice questions over this section to help you out. Thanks.